Well, good morning and welcome. My name is Cheyenne. I am going to be moderating this session with Maggie over here. So thank you guys for coming. It's so good to see a lot of you guys in person. I feel like this is a family reunion and we get to meet some new people. So I am really excited. It's been a long time waiting. So thank you guys for coming. And there are still some seats up front. Don't be shy. For all of you guys that's standing back, I'm giving you a chance to come and sit and find some seats. But anywho, we're gonna go ahead and get started, and there's gonna be some new stuff for us to learn, so just bear with us this is our first session and testing out the equipment. So at this session, in case you're not sure what session you're in, this is a RTPT session, and it is going to be we're going to talk about how, with the approval of the highly effective modulator therapy, has changed in a lot of our practices, such as treatment burden and things like that. So we will examine these airway clearance techniques, inhale mucolytics, exercise, and so on and so forth. And we'll also see the new changes, such as increasing pregnancy rates and transplant referral and how that affects our disciplines. By the end of the session, you should be able to answer most of these objectives, and you can read those on your own. And so now for the technical part. So at the end of each speaker, we will do our Q&A. You'll see this slide show up, and this is where we're gonna do like a PDSA for those that know quality improvement. We're gonna test this out. So on your phone, you're gonna go into the app, and then you're gonna go into where you can see our session right there. Click on that. That will take you to this page. And then you'll click on the first top part, which is the main part of our session, which then will take you to this page. And then the bottom of it, you'll see a Q&A. So do not click on the chat box. I cannot see that. It needs to be in the Q&A box, okay? And then it'll pull you up to this page where you can ask the questions. The reason why I'm doing this is that the QR code they have sent us is not for our session. It's for 2 doors down. So I'm not sure how this is gonna work, because unless you're in session 4 and we're here in session 6, I'm not sure if I can see your answers or not. So if that doesn't work at the end, I might have you guys just stand up and use your big voice and do that if this doesn't work out. So just heads up for the technical difficulty. Any questions? Okay, so I would like to go ahead and start. We have an amazing panel of speakers. We have an international, actually. We got some speakers coming from Australia, from Canada. So this is gonna be super exciting to learn from all of us. And I'm gonna have Maggie here introduce our very first speaker.
Okay, still people at the back. There is a few seats at the front if you want to come forward and get a few seats. Okay, so the first speaker today is Dr. Brenda Button, and Brenda is an honorary clinical associate professor. She began her career working in pediatrics and then transferred to the Royal Alfred Hospital, where she's now working at the adult CF clinic. And Brenda is going to talk to us today about airway clearance in an era of modulators. So over to Brenda.
Good morning. Thank you very much to the organisers for inviting me to talk to you today on a topic that has very little research to draw from. So from here we'll see where we go. I'm not moving. It's not moving forward.
Oh, yeah. Yours is not moving forward here. Let's try this. And then go here.
Okay.
This button. Let's see. I gotta go back one. Just use this button.
Okay. So I have a number of disclosures, but none that no conflicts with this presentation. So the objectives of today is to look at the impact of highly effective CFTR modulators on physiotherapy, and on people with CF, and particularly on airway clearance, including exercise and adjunctive inhaled therapies. We'll see what little bit of evidence there is, mostly in just presentations at conferences so far, and what the implications of structural lung damage, we will discuss how that might impact on our thinking. So my session will probably raise more questions than answers. I'm not going to talk about gene modulators. You're all familiar with them all, so we just assume that we are all with that. And when it comes to impact of these modulators on our people with CF that we work with, these are the common things that we get to hear. The life-changing improvements that have occurred, that initial surge of sputum, which then seems to decrease after a few days to very little or even nothing, decreased cough, sleeping better, stopped vomiting, all the things that cough caused, like vomiting and urinary incontinence, all seem to improve once that happens, less low back pain. Some will say, the first time I can breathe through my nose. So sinuses seem to clear as well for many, not all. More energy, more motivated with exercise. Some have got fitter, more stable, fewer exacerbations. A few have had some mental health issues. And then pregnancy after trying for a long time. That's a common story we're starting to hear, even people with very low lung function. We did an international physiotherapy group benchmarking survey, which was presented at the European CF conference this year, where 33 out of 41 countries of physiotherapists and RTs around the world respond, with 186 respondents, about how they saw the impact of gene modulators on physiotherapy, airway clearance, etc. And these were some of the comments. They were just open-ended questions. How have you found gene modulators in your clinic? Fewer and shorter hospital admissions, less oxygen use, less shortness of breath, just fewer symptoms generally. Everybody feeling more well, more active, improved quality of life. Some have increased exercise capacity, greater patient adherence, some saw that. Not everyone sees that, but that was one of the comments. And self-management and collaboration, an improving situation. Decreased number of severely ill patients. I think we're seeing that in our hospitals, particularly that patients are much more stable. Fewer inpatient treatments, fewer aerosol treatments required. Getting sputum up for some is much easier. For others, there's just no sputum to clear at all, except when they're in exacerbation. More admissions now for other things like gastro and other surgeries, other issues. The importance of ongoing education to patients, as was highlighted in this survey, and the importance of using the huff at different lung levels when people are using exercise as airway clearance, which some are doing. Many countries, and this came up at the conference with quite a lot of discussion, do not yet have CFTR modulators. And there was a lot of discussion about the lack of equity to patients around the world. At that time, there were something like 12 countries that had these modulators. And what about all the other patients in all those other countries where they're not available? That created a lot of discussion too. So to come back to a little bit of evidence that we have, this is at our centre between 2014 and 2019, before triple therapy came on board. So we're seeing that our hospital admissions are decreasing, our hospital in the home in blue bars, that's patients having IV antibiotics at home, is decreasing, but our patient numbers are increasing because we still have children who come across and transfer to our adult centre. And our hospital admission days have just really plummeted, which is a fantastic thing for our patients. So, real-world patient reports in our clinics. What are we hearing from patients? And these are common stories, I'm sure, around the world. Many patients tell us, and these are just random comments that we tend to hear, that they've halved the number of airway clearance sessions per day. So if they used to do twice a day, they're now doing once a day. Maybe they're only doing it on alternative days. or a few times a week when they feel congested. Stopping airway clearance when they're well, because they're not expectorating sputum. Some of them will say, I can't even get a sputum sample up, so why should I be doing airway clearance? Some are using their Dornase alpha Pomazyme daily on alternate days, a few times a week, or only when they feel it's necessary. Hypertonic saline, often they combine with their airway clearance. So those two, the pictures on the left, on the your right, show how you can combine them with some of our airway clearance devices, which means they get 2 treatments in the time of 1, which makes life very efficient and effective for them. Some have stopped formal airway clearance but are using exercise instead with huffing, and others have stopped doing airway clearance and inhaled therapies and continue on a sedentary lifestyle. So those are probably the ones that give us the most concern. This is a case of one of our 19-year-olds who had very low lung function, and she was on the lung transplant waiting list, having half a cup a day of sputum, a cup a day when she had exacerbations, struggling to keep up with friends, fatigued all the time, frequent admissions, very poor quality of life, and did not qualify for Orkambi or Symdeko. But we then got compassionate Trikafta for those with very low lung function, and she started on Trikafta, and within a very short time came off the lung transplant list. Her sputum was down to less than a tablespoon a day. She stopped on her own volition. This was all in the middle of the pandemic, so that was another issue which really impacted on how much and how often we saw people, particularly face-to-face. So she'd stopped all her treatment, and she then had an admission because she was just not feeling quite so well after a few months. And we found her CT scan were mucus plugged from one end to the other. So we started all her treatments back, got her back to where she was before, and she's now started a very vigorous gym program, 6 days a week, and doing huffing with that, markedly improved quality of life. She's moved out of home, she's moved interstate, and her life has just completely changed. But I think this highlights some of the common things that we're coming across, people with low lung function who then stop all their treatments and really get into trouble. What evidence is there out there? This is mostly from the European CF conference, which was in Rotterdam this year. Here we have impact of triple therapy on airway clearance and nebulizer adherence, and we're seeing some evidence that it really is decreasing across many centres. So here's somebody with a lung centre with 112 patients with FEV1s that increase over time, over 12 months, and then improvements of FEV1 and ease of airway clearance seen by 3 months. So that seems to be a pattern, that by 3 months you're already seeing these changes. Sputum surge in 63% of patients, and then they reported adherence to maintenance therapies decreasing after starting. So 64% at baseline and decreasing right down to 37% by 12 months. And the same with objective nebulizer data, decreasing over time. Then we have people on triple therapy demonstrating improved physical activity and cardiovascular fitness, and this came from the Liverpool group using CPET, 30 patients, and we showed that they had an increase in peak VO2 and an increase of FEV1, which was significant. And these two correlated, and the peak VO2 in 8 who did not exercise before or Trikafta before or after was less. So if you don't exercise, you don't get the benefit, and I think that's a message that's coming through quite clearly as well. The need to accompany modulators with exercise advice and formal support is really important so that we achieve the most improvements in cardiovascular health and fitness. Another study that we did, which we presented at the conference, was looking at quality of life and fitness using our Alfred Step test. And we showed that this was only in 10 patients who we had compassionate access to Trikafta because we weren't yet registered. You can see low lung function, age varied there, 30 to 48, BMI, and their quality of life scores improved significantly over 26 weeks, as did, and that's our OR score, which we now have in English, Spanish, and French, a very quick 1-minute quality of life questionnaire. And then when we did our step test, which we will present on later today, we found that they increased the number of levels in their step test, their resting saturations improved, and all patients reached a maximum effort test. That's our documentation for the test, and again, we've translated it also into Spanish and French. Urinary incontinence was another thing that seemed to decrease after starting triple therapy. This was a group from Oxford, median age 25, 29 out of 90, 31% had urinary incontinence at baseline, and in the first 12 months this decreased significantly, and therefore was much less of a problem, probably because they had all stopped coughing. That seems to be the message that we get through. But we need further studies to understand the long-term effects of triple therapy on urinary incontinence. There are a number of trials now that are happening, which I'm not going to talk about, which we're looking forward to getting results, hopefully at this conference. The Simplicity, the NEMO study, the HERO study, CF Storm, the EXACT trial, which is an exercises airway clearance therapy trial, which is starting in the UK. And in Australia, we're trying to develop a trial too, to compare exercises airway clearance versus the traditional techniques. So this is a watch this space. It's in the process of being developed. We're trying to come up with a protocol that will actually assist everyone in feeling comfortable with either stopping one thing or the other, and how to randomize that, a very difficult study to put together, because patients are very concerned, some about stopping airway clearance, whereas others would be very happy. But how do you randomize those and make sure that you have a clean trial that doesn't affect one group, doesn't affect the other? However, we still have bronchiectasis and structural lung damage. This is long-standing, and what happens to these damaged lungs on triple therapies? Can they repair? We doubt that they can, but this is still, I guess, early days to know how much repair can occur. So this is what we're dealing with. CF with our modulators, patients stopping treatment because of these decreased volumes of sputum, decreased cough. They're stopping doing things that they've done for many years, and they still have the structural lung damage. The debris is still collecting in these dilated airways, and the cilia are destroyed. Are they going to repair? We doubt. Do they still need to move this debris on a daily basis? And future clinical trials will inform our practice. So what do we do as therapists in our clinics? Patients tell us that they've stopped doing things. Some of them are replacing airway clearance with exercise, and some are ceasing or only doing intermittent mucolytics. Do we just monitor N of 1 outcomes at this point in time? And what do we monitor? Lung function, radiology, and symptoms. Maybe we really need to sit down with our patients and show them their CT scans, show them their chest x-rays before they start modulator therapy, and then convince them that maybe they need to keep doing things until we know more about what the effect will be from stopping. So with the structural lung damage, we are advising our patients that they should keep going, that they should not stop everything, that if they are stopping, they should definitely be doing huffing with their exercise, And we are certainly encouraging all of our patients to exercise. That is something that all humans should be doing. It's the elixir of life, and that they should be doing that as well, regardless. So in summary, we are finding that our patients are decreasing their own treatment burden, and they're doing it in various ways. And I think the being in a pandemic didn't help us, because many of us were not seeing patients as often as possible and as usual. And there's no evidence to date to guide our clinical practice. So everyone is going blind in terms of what we tell patients, which of course we would all prefer them just to keep doing what they've always done and get the most out of their gene therapies as well. There are numerous trials underway with lots of different outcome measures. And we believe that patients with established bronchiectasis should continue doing their treatments, and we need to educate them about their risk benefits. Exercises airway clearance with huffing has promise, and there are trials coming, but that's not going to be for everybody. Future trials need to be large, robust, and probably multi-centered. And we need to rationalize the treatment burden without, without compromising outcomes. And I think that's our biggest challenge. And these are some of the references that have gone with that. So thank you for your attention. This is one of our websites in Australia where physiotherapists and patients can go and learn about all forms of airway clearance, and it's available to everybody worldwide, and it can be a useful resource to keep encouraging our patients to keep doing what they probably need to do. And I thank you for your attention.
So thank you guys, and thank you, Brenda. I'm having a little delay on the app, so I'm trying to use it between my phone and the iPad, so thank you for being patient. If I don't see your questions, not because I don't want to ask, but we'll go with it. So let me go ahead and start with the ones I do have. Let's go with, is the A-step test validated for patients with CF in terms of norms for the results of testing, or do we just compare it to the patients themselves?
Okay, so at the moment we're just comparing it to the patients themselves. We're in the process of starting to validate it against CPET. We'll be talking about this in a workshop later today, where we'll give much more detail about it. Its protocol has been published in Pediatric Pulmonology, and we've done a feasibility test which has spanned between age 10 years and old age. So it is a test that we're trying to do to be able to compare exercise over a whole lifespan, rather than having different tests when you're young and then different tests as you get older. And we're trying to really develop a test which is absolutely a maximal test. At the moment, we know it's a maximal effort test, but the next step is to compare it with CPET in a randomized study and work out whether it is truly a maximal test. And of course, it's a field test that we can use in our clinic settings.
Okay, thanks, Brenda. Another question was, how do you support patients who stop their therapies? Some patients have just given up and stopped it. What do you advise them to do in that case?
We try to work in a motivational interview way as a team with the patient. And when they come to clinic and they say, I've stopped everything, and we know their lung function is low, and we know they've got bronchiectasis just from the past, we'll actually sit in the clinic and open up and have a look at their most recent CT scans, maybe some chest x-rays that we have if we haven't got CT scans, but usually we do, and say to them, well, look, you've got all this damage here. What do you think about this? You've stopped all of your therapies. Wherever there's damage, there's going to be collections of debris because the lungs are supposed to be cleaning themselves all the time. And in areas of bronchiectasis, you're not really cleaning them because the cilia have all been destroyed. So you're going to get this continual buildup of mucus in these areas. And then you're sitting with a situation where you're likely to start developing infections again. And then your lung function is going to drop, which is what we do see in some patients. And that's often the reason why we get them into the hospital and start having to do tune-ups and things again, and give IV antibiotics and start the whole process again. And from my experience, by sitting down and rationally looking at all of this with the patients and then saying to them, so what do you think? What do you think would be the right thing to do in this situation? And I have to say that when you approach it in that way, you look at their lung function, which has maybe dropped a bit since they first started, when it had improved, and maybe they've got a few symptoms, maybe a bit of dry cough, or they're just not feeling quite as well as usual. And we see that on this quality of life or score, the Alfred Wellness score. Often you can pick up they're doing less exercise, they're sleeping not as well, they've got some mood issues, and they're just not as well as they were before. And by saying, so what do you think about all of this? The patients will often say to us, I think I need to start doing something. Maybe I need to get back to doing airway clearance as I did on a regular basis every day. Maybe I need to start doing my pulmozyme on alternate days, or maybe every day. And we then come up with a bit of an agreement, or a bit of an approach to how they might have some goals, and then we monitor that very closely and carefully. And if then they pick up again and their all score improves and their lung function improves and they're doing more exercise, that then often means that they then become convinced this is what they need to do.
So thank you, Brenda. We have maybe just one more question, and then if you guys see, there's multiple of you guys asking the same question, you can and then that will put us the same question up so we don't get repeats, just in case you're wondering. We're trying out this app. And then the rest of you guys, I think your answers will be coming in the upcoming presentations as well. So this one is, can you speak to your recommendation on exercise dosing when paired with HUFs or ACT?
So as an alternative, could you say the end of that again?
Yes, as an alternative.
Okay. So if you're doing exercise, a lot of our patients will actually suppress their cough, say, when they go to the gym. They don't like coughing a lot in front of people. So they'll do all their exercise, they'll mobilize secretions, but they'll actually then suppress their coughs, for example. Or they just don't bother to think about clearing secretions anymore. They just go out and maybe go for a walk or do some exercise, but then don't go about actually trying to clear secretions. And the advice and the suggestions now are that one shouldn't suppress coughs when you're around people, and maybe you need to go off to the bathroom and go and do some coughing and clearing. But that maybe on a daily basis, as you're using exercises, airway clearance, that you should check your airways by exhaling all the way down to the lower lung volumes, hearing if there are any secretions, doing some huffing from low, mid and high lung volumes. Some people use autogenic drainage, where they take a big breath in and then a breath all the way out, and listen to where they might be hearing secretions on that breath out. And if they're hearing any rattles and crackles and secretions, then they know that they should probably be doing some proper formal airway clearance, but at least doing some huffing and some coughing to clear. So I think that's kind of a suggestion that we're making now, is that everybody should be doing some huffing on a daily basis to at least listen to their airways and hear whether there are secretions down in those small airways, as at least a minimum to do with when they do exercise. But we're certainly not encouraging those who normally have bronchiectasis that's already developed and who have lower lung function. We're not encouraging those to stop their treatments at all. We're encouraging them to keep up with at least some of them, if not the whole lot that they have done in the past.
Thank you, Brenda. Really appreciate it.
Thank you.
Our next speaker is going to be Maggie, and she is the PhD currently associated with clinical professor, University of British Columbia. She's also the network manager for a CF Canada Accelerating Clinical Trial Network.
Okay, so first of all, I would just like to thank the organisers for inviting us to speak at this conference, and I think this is a really important symposium to have because we are changing how we are approaching both airway clearance and inhalation. So the question is to inhale or not to inhale. Thanks. And how do you get advanced forward again? It's not advancing forward.
No, you have to go here.
Oh, here. All right, thanks. Okay, thanks. Okay, so I have no disclosures that are related to this presentation. So as we all know, cystic fibrosis, it is caused by a mutation in the CFTR gene, and it results in reduced CFTR protein activity, defective chloride secretions, and we have then deficient fluid secretion, and the result is our thick and sticky secretions. And this results in a vicious circle here. And the treatments have been so far is for infection, we use inhaled antibiotics. For inflammation within the airways, we use anti-inflammatories. And for mucus obstruction, we use inhaled mucolytics, hypertonic saline, airway clearance, and exercise. But now we have come into an era of modulators. We want to know how does this affect our inhaled amount of inhaled antibiotics, the anti-inflammatories, and also our inhaled mucolytics and hypertonic saline. So these are the types of inhaled medications that we're presently using. Mucolytics is Dornase alpha or pulmocine. We have hydrators such as hypertonic saline and mannitol in some countries, although I'm not going to talk about mannitol. We have inhaled antibiotics. Most common ones are tobramycin, colistin, and acethem. And we also then have the inhaled beta agonist. Some centres are using inhaled steroids, inhaled anticholinergic. For this talk, we're going to focus on the mucolytics, hydrators, and inhaled antibiotics. And we're not going to be looking at the beta agonist steroids, etc. So the interesting thing is, this is before these countries, before the UK, Canada, or the US started on modulators. What was the present use of? And you can see it varies quite a bit between countries. You can see, for instance, Dornase alpha in the UK, 62% of children and 73% of adults were using it. However, when you look at our Canadian registry, only 36% of children and 45% of children were using pulmocine. In the States, 76% of patients are using hypertonic saline, 87% of patients are using Dornase alpha. When we look at hypertonic saline, both then the UK registry and Canadian registries are somewhat similar. But again, in the US here, hypertonic saline, 76% of patients are using it. So how does this affect our patients? We're first also going to look at inhaled antibiotics, and you can see that the most common inhaled antibiotics, both used in Canada and in the States, is inhaled tobramycin. In the US, they portray it as total number of patients with the ages, and then this bar here is the number of patients, sorry, it's not showing here, but maybe hopefully here, sorry. Sorry, we lost it. Oh, I'll just go back again. Hopefully we'll get it. Yeah, all right. Yeah. Okay, so the bar, we won't see it, but just the blue bar here is the number of the patients that are using the tobramycin. Okay. So, but what is interesting is, as I said, the burden of care. So if you looked at the US data, the red line is showing that the percentage of people on all three medication is about 40%. And this has taken a long time to do all of these medications. And you can see that most of the patients are about 90% are on at least one inhaled medication. So I said this does put a burden of care on families. We did a survey in Canada and we looked at the different surveys amongst the different clinics, and you can see that patient to patient, they ranked airway clearance. 44% said it was very burdensome. Inhaled antibiotics was 41% very burdensome, and you can see also hypertonic saline and Dornez alpha all ranked high for the burden of care. We also looked then, published data on the treatment time to do these therapies. And you can see here, that the mean total time people were spending doing nebulized therapies, airway clearance, exercise was about 108 minutes a day. That's nearly 2 hours a day our patients are spending doing this. A Canadian survey, we also looked at our people on modulators once they started Trikafta and looked at what was the effect of reducing the treatment time. And you can see here that the treatment time, the mean from 18.7 hours decreased to 14.1 hours of treatment. This was per week. But it's still 14.1 hours. That's still 2 hours of treatment a day. When we look at the clinical trials, and this is based on ivacaftor, you can see that the real-world evidence demonstrates that patients, after they exit a clinical trial, that they still have a decline by year 5 in ivacaftor after ending the trial once they were on it. Is this because patients are stopping their therapies? And this is still a question that we need to answer. Again, looking at our Canadian survey of people, asking them, have you stopped any therapies? What has been the change since you started triple therapies? They reported 63% said they had reported decreasing their inhaled medication. Airway clearance by 48%, anti-inflammatories by 30%, antifungals by 26%. And again, you can just see here what the children responded was slightly different. But you can see that our patients, without us giving them any direction, they are choosing to change their medications themselves. This was a retrospective chart review out of St. Paul's Hospital by Song et al., just published this year. And they did a retrospect chart audit on people with triple therapy. And they actually went to, in Canada, you can actually go and look up the pharmacies, the number of prescriptions that were picked up for nebulized therapy. And they looked at it 1 year pre and 1 year post-ETI. So I said it was a retrospective chart review and looking at their medication possession through Forminet. And you can see here that, this was 3 years pre, the first one, and 2 years pre, 1 year pre, and then 1 year post, a significant decrease in the amount of nebulized medications they were picking up. Now, the PROMISE study has given us also a few results and showed that inhaled antibiotics, by the time of 6 months, that we had a reduction from 51% to 33% of patients using inhaled antibiotics. Hypertonic saline, also by 6 months, we had a decrease from about 75 to 68%. And Dornez alpha, there was a decrease from 87% baseline to 81%, just a slight decrease in that. So, we are seeing that, one, these inhaled medications are time-consuming, they're burdensome, our patients are stopping them on their own. So where do we go from here? We have 5 trials that we're looking at this, and Brenda alluded to them a little bit. There are 2 that are interventional trials, and there are 3 that are observational real-world trial. And I'm just going to go through these and talk a little bit about each of them. So the NEMO trial this year is a multi-center observational cohort, and it's in the UK, and they've got a patient hub. So it's not having to bring patients to clinic to do this study. It's all done virtually with the patients. So it's looking at the real-world effectiveness and in the UK, it's called Kaftria for Trikafta. They're looking at the efficiency effectiveness gap for trio amongst adults, and they're looking at the change in adherence to this among adults. And then, and what is the impact of this? So the data that they're collecting at is looking at the age of starting, Pseudomonas status, comorbidities, I said adherence. They're looking at some things when they body mass index and prescribed medications, and just what is their healthcare utilization. So this here is it's going to be a 5-year study, and they're looking at 5 years. Looking at 5 years post-initiation. The HERO study is one that is here in the US, and again, it's home-reported outcomes for people with CF taking the Trikafta. It's a 12-month study looking at to assess the impact of triple therapy in the daily use of chronic CF medications and treatment. It's a phone-based patient-reported outcomes application and using data from the CF registry. Eligibility is more than 12 years, and the primary outcome has to be FEV1 predicted. So far, this is where we are in this trial. Unfortunately, I have to say, these trials have started, but they haven't yet been completed, so we can only give interval reports at the moment. But you can see that there's 23 sites, we've got 23% of sites recruiting patients. Their referral site is 47%, and they are just starting to collect all the data, the daily tracking, the monthly phone call, and then at the end of the study, they're going to be also then collecting the registry data as well with that to support this study. Okay, right. So here, this is the self-reported changes in therapy when at the start of the study from patients. So 95% of patients completed the study start questionnaire, and you can see that a high percentage had already reported stopping their inhaled antibiotics and airway clearance, Dornase alpha and hypertonic saline. About 20% of each of those had already done it. So we're going to look at a 12 months post-initiation of this trial and see what has happened. The one interventional study is the Simplify, and I'm sure most of the people in this room are aware of it. It's looking at the impact of discontinuing chronic therapies in people with CF who are on Trikafta. So it's a multi-center US study with patients over 12 years of age and looking at nebulized hypertonic saline or Dornase alpha. And they've had to have an FEV1 of 60% and be over 18 years of age. It's a 6 weeks participation, and the reason why they only chose 6 weeks as a short time for this study, they wanted to make sure that the patients were totally adherent to this study, and so using a longer term, they could not guarantee that patients would be adherent to this trial. You can see that there's 3 arms, a trial design. I'll just take you through it. So the first one is certainly screening. And if patients on hypertonic saline, then the first group, they are randomized either to stop or to continue the hypertonic saline. And as I said, then they're monitored every 2 weeks for 6 weeks. There's some of the people that I said that are on hypertonic saline and Dornase alpha, and what they are to, they can be randomized either just to the hypertonic saline group or to the Dornase alpha group. And again, once they're done to that group, they again are randomized either to receive or not to receive their treatment. And then the last group is the ones that are on Dornase alpha only, and then they're randomized either to continue or to stop it, and looked at 6 weeks. The results of the Simplify study are actually going to be presented tomorrow at Symposium 15. I tried to ask Dave Nichols, the PI, to get a little tidbit of what's been presented, but unfortunately they wouldn't give me anything. But we tried, just to say, but they are only given, it's only interim analysis, and they're only given the primary outcome results tomorrow. So go look at Symposium 15 if you get a chance to it. The other interventional trial is the CF STORM, and that's in the UK. And again, they're randomizing, it's an open label trial, and they're randomizing patients to either continue on nebulized hypertonic saline or Dornase alpha. It's a 12-month. It's a 12-month study. Again, the primary outcome is FEV1. Data is collected at clinic visits and entered into the national and data that's entered into the national registry. And they are using also in their nebulized adherence. A lot of them have tracking devices on their nebulizers so they can actually track their adherence. So I said it is a registry-based study. So far, update from that study has been that there's 33 sites are currently open to recruitment, and so far they have recruited 224 patients already. So again, by next year, we should have the result of that trial. Last trial is our Canadian CAN impact study, and this is a prospective observational study, and it aims to understand the long-term clinical impact of CFTR in people with CF. So it's a real-world evidence study with a 5-year follow-up, and we're doing eligibility from 6 years upwards, and we've got 10 sites composing of 13 clinics. For this study, the patient populations were in 4 defined groups. Either we looked at those that are pre-therapy, that have not started the modulators, and we'll follow them through. Some are late entry participants that have already started the CFTR modulator, and we'll just collect the data from there and on. And then there's a non-modulator control group who are ineligible for CFT modulator. We're following them as well. And lastly, we're looking at historical controls as well. This study is collecting a lot of data. The one big difference is that this study is actually looking at the mental health as well, at the PHQ-9 and the GAD-7, which none of the other studies are looking at the mental health. It also has a lot of questionnaires, and we're trying to look at getting more to the things that, and this is, our patients give us a lot of input into this, and they said, work productivity can be affected, or activity can be affected, so we're trying to look at all these parameters as well in this trial. So lastly, where do we go from here? We're just beginning to gather data about inhalation therapy, post-Trikafta. Some are done by randomized controlled trials, and some are just real-world evidence. We're hoping that NEMO, HERO, CAN Impact will tell us what's happening in the world of with patients in the world of modulator therapy. But we also have 2 interventional studies that will provide also more information to this on the discontinuation of our inhalations. But we need to also consider the following for our patients. We need to look at the age at which the modulator was started. As Brenda alluded to, the type of lung disease that are already on, the type of modulator, looking at the burden of diseases as well. If they are going to give up some treatments, how do we instruct our patients, what's beneficial that they need to continue, what can they change within their lifestyle. Some people believe that modulator is a cure and they stop all their treatments, and that's not good. Especially, when Brenda alluded to what happens afterwards, that you may get a rebound. We are going to need to personalize our approach to patients, individualizing it to their lung disease and what's going to work for them. I just want to thank, everybody has helped me with this. For the CF STORM, Pamela McCormick has given me input on it, Simplify, Dave Nichols, CAN Impact, Alan Lacana, and Tracy Daniels for NEMO, and for the CF Clinic at BCCH, and Brad Kwan. So thank you.
Thank you, Maggie. So make sure you guys enter. I'm starting to figure out all this stuff. If you want it to show up on my iPad, it needs to be under questions and not discussion. So then it'll pop up. So for your first one is, how do you approach inhale antibiotic use when patient also self-wean these treatments?
Sorry, when patients what?
Self-wean.
self-wean patients. I mean, I think you have to observe the patients. If they choose to do this, you need to look at what are the outcomes from those patients. But it may be more, I think, important to look at, just decreasing it rather than actually stopping it for some patients. Also looking at the underlying physiology. I mean, if you're using Trikafta, it has been shown it increases mucociliary clearance. We are going to have thinner secretions, but it's just still, there may be still some mucus plugging in some of the smaller airways. So they may need to continue their Dornase alpha to help to get that smaller airways. So it has to be individualized to the patient.
Thank you. The next one is, do any of the studies use chest CT as an outcome measure?
Yeah, that's one of my big peeves is that we haven't done a study looking at airway clearance as an outcome measure. Brenda alluded to some studies that are starting both in the UK and Australia. For the kind of impact CF, I'm going to ask if that can be included in the questionnaire. We will be able to look at our Canadian data registry where patients do report their airway clearance, and so we will be able to look at this through registry data with patients who are on kind of impact.
Okay, I think that was good.
Okay,
Thank you so
all right,
much.
thank you.
And then for the speakers, just want to make sure that if there's any unanswered questions, you guys can type in your answers later to the audience and then send it.
Okay, so I'm just going to introduce our next speaker, which is Dr. Larry Lands. Many of you know Dr. Larry Lands. He is the director of the CF clinic at McGill University, and he is attending physician in the Quebec transplant clinic. So welcome, Larry.
Okay, well, thank you. And I want to thank the organizers for the invitation. It's really great that we're all back together and that we can talk about things like modulators and exercise. And which one? Oh, I got to use that one. Okay, great. Okay, for the purpose of this presentation, I have nothing to disclose. So, recent international study has looked at prognosis and exercise capacity, and those with a lower exercise capacity have a worse prognosis. This was shown many years ago, but now things have changed since that was shown. We have newer therapies, and it still holds true. And the other branch of the study was large international, North America, Europe, Australia. So it really applies to everyone. And frankly, whether it's a healthy population or patients with other chronic diseases, exercise capacity does have an impact on mortality. So there's a variety of factors that do influence your exercise capacity. We certainly, does the pointer work? It works on the screen, but not on my screen. Okay. We certainly know that lung function can affect your exercise capacity. Cardiac function will also affect your exercise capacity. Delivery of oxygen to the peripheral muscle that's doing the exercise, so vascular aspects, especially the microvasculature, capillary density will impact your exercise capacity. And finally, aspects related to the muscle, the skeletal muscle itself. And some of this could be related to deconditioning and nutritional aspects, but there also are the potential that there could be some impact of CFTR mutations on mitochondrial function. However, again, using this international collaboration, we did look at the impact of CFTR mutations, compared those with more significant mutations, class 1 to 3, and those with milder mutations, class 1 to 4 and 5. And when you correct for sex, age, lung function, nutritional status, so the factors that typically have an impact on your exercise capacity, you can see in terms of maximal exercise capacity, whether it's Wmax or VO2 max, there really is no difference. And so the impact of the specific mutation really isn't there. And so we need to look at what else really does impact maximal exercise capacity. So when you look at lung function, here I'm going to use the forced expiratory volume in 1 second, or the FEV1, which we all do, we all measure in all our patients. The more you have in terms of lung function, the greater your maximal exercise capacity. So the exercise capacity is VO2 max done by a standard progressive exercise test on the cycle ergometer, which is the recommended exercise test for cystic fibrosis patients. You can see in full squares, which are CF patients, they are adolescents and young adults, and the open squares are healthy young adults and adolescents. You can see that there's really a continuum. The better your FEV1, the higher your VO2 max. We also looked at this in an older population, so older healthy adults in the open red squares, and those with chronic obstructive pulmonary disease, COPD, in the blue squares. And again, you can see it really is a continuum: more lung capacity, greater exercise capacity. Okay, but we also looked at muscular capacity as well. And here we used an isokinetic cycle, so that's a cycle that fixes the speed, and you can measure the work output. And we looked at the work output over 30 seconds. And there again, there's a very consistent relationship between the more you could do with your legs, the higher your exercise capacity. And again, the CF patients are in solid black squares, the healthy were open, and the same relationship was also seen in older healthy adults and those with COPD. And the main factor that affects leg exercise capacity, and I apologize, the y-axis should really be there, the 30-second isokinetic work output, but the more muscle mass you have in your legs, the more you can do in terms of your leg capacity. And actually, if we put our FEV1 together and the 30-second work output, we have a very good predictor of what you can do on a progressive exercise test. The lines in both figures is the line of identity. The upper figure, the black and white figure, is healthy and CF, and the colored figure is older healthy adults and those with COPD. So we do have these two factors that really will impact exercise capacity. However, just improving your lung function won't necessarily get you changes in exercise capacity if your leg muscle function is markedly diminished. So this is a study that we did in lung transplant recipients. We did single lung compared to double lung, and you can see there's a big difference in their FEV1, 56% versus 86%. However, when you look at their maximal exercise capacity, there really is no difference. And similarly, even if you lose lung function, if you can maintain, unfortunately didn't look at leg muscle function, but they looked at muscle mass. If you could maintain your muscle mass, you could still maintain your exercise capacity. So in that context, let's think about what we're getting out of highly effective modulator therapies, and this is Trikafta. And we can see that there's a significant rapid increase in FEV1 that appears to be sustained. We also see that the body mass index will also go up, and it goes up pretty fast. However, and the reports are scattered, small case series. Where's that body mass index going? And a lot of it's going to fat, and some of it's going to muscle. You could argue, we've all talked about patients have a lot less secretions. So mucus is made up of mucins, and mucin is a glycoprotein. So it's really nice if you're not producing mucus that you can take the amino acids, the energy that you were spending on making mucus, and direct it towards muscle. But it's not going to happen all by itself. And so what modulators won't do is get people to be more physically active. And we know that the amount of habitual physical activity that is done has a positive impact on your exercise capacity. And just to remind everyone, the recommendations are for children that they should be doing an hour a day, at least 5 days a week, of moderate to vigorous activity. That means they should be somewhat shorter breath. They shouldn't be able to sing along with their favorite TikTok while doing it. And in adults, it's 150 minutes per week. And it doesn't have to be in one big block. There's a minimum of at least a 10-minute block. So how can you do this? Well, you can put them in a well-supervised exercise program, and as you can see in the left side panel, that maximal exercise capacity will go up. However, people maintaining this type of program, it falls off, both their interest in doing this and their actual continuing to do it. So this it has short-term effects, but doesn't have sustainability. Now, so we'd like to motivate people. And it'd be wonderful if we had trainers, nutritionists, psychologists, writing teams, all helping us to, reach the goals that we want our patients to do. So before anyone comes up and slaps me, let me suggest that we can do something else. So this was the reason behind the recent Activate CF study, which was a multinational study. And it was a study using a 6-month semi-supervised exercise program, used motivational techniques, and I really appreciate that Brenda brought up motivation before, and also that she mentioned that UK trial that those patients who didn't increase their physical activity didn't increase their maximal exercise capacity. So our goal was to add 3 hours a week to those who are doing less than 4, so less than what's recommended. And we really were looking at can it improve lung function. So who was enrolled? Now you'll see here we had, I won't say lofty aims, this was what statistics suggested. We wanted 292, and you see that we finally assessed 155 and enrolled 117. And this wasn't for lack of effort. It went really around the globe. But there were those patients who already were physically active. There were those who weren't physically active and were interested in being in this trial. And then there was a fair number of people who were not physically active and frankly were not interested in being motivated to be more physically active. So this is where we got. So who was enrolled? It's fairly typical considering it was 12 and above, so the average age was young adults, slightly more women. I wonder if women are more motivated to be physically active and get involved in such programs. They had a good nutritional status, and their FEV1 was fairly typical of what we would see in this population in the low 70s. And as you can see, their habitual physical activity at the beginning was about an hour and a half, a week. So less than what was recommended. And it was purposeful that's how you got into the trial to be in this. So what did we do? So the goal was to add 3 hours of vigorous physical activity a week. And we wanted a mix of strength training and aerobic training that started off with interviews by trained interviewers to talk about what type of exercise the people like to do, what were their interests, what were their barriers to doing exercise. And then together with the patient, there was the development of a personalized recommendations, and there was a signed agreement. They had ongoing counseling throughout, in person, plus there was phone contact. And they also had to fill out a web-based questionnaire They were supposed to fill it on a daily basis, and if there were several days with no entries, the program would actually send them a notification saying, hey, we haven't heard from you, let's hear from you. So what happened? So the amount of time spent in vigorous physical activity went up. Now, it didn't go up to 3 hours, went up about 2 hours, and about 56% of the patients did at least an extra 2 hours of activity a week than they were doing before. But what's most interesting and most useful to take away from this is this was a 6-month program, but that effect was maintained over a full 12 months. So it seems like we were able to enact a behavioral change that was sustained. Now, and I'll come back to this shortly, but much to our surprise, and remember that our primary outcome was that we were going to see an increase in lung function in those in the program, it was the control group whose FEV1 went up, and not in our not in the intervention group. We did see, though, however, that exercise capacity went up. And again, it was maintained over the 12 months, even though this was a 6-month intervention. So what do we learn from this? Well, it's unclear why the control improved their FEV1 at 6 months. There didn't seem to be a difference in time to first exacerbation or infections or antibiotics use or modulator use either. It just happened to work out that many patients in the intervention trial were often seen just prior to an exacerbation, so maybe that's why their lung function looked a little worse. And there weren't that many exacerbations in the control group either. And some of the control group on their own decided to be more physically active than they were before. However, our intervention group did increase their amount of physical activity, and that was maintained over the 12 months. And their maximal exercise capacity also went up, and that was maintained over the 12 months. So we think that probably a steep increase, asking someone to go from nothing to adding in an extra 3 hours a week, is probably asking too much. We do really think a motivational program is the way to go, but perhaps we should be aiming more for, let's start with a 10% increase in regular activity and build from there. So in summary, exercise capacity is dependent upon lung function, skeletal muscle function and mass, and habitual moderate to vigorous physical activity. The benefits of highly effective modular therapy requires an increase in muscle mass and physical activity, in addition to improving lung function. And finally, tailoring a motivational program with reasonable expectations can improve exercise capacity, and it looks like it can actually impact regular behavior change that will instill in people to continue to be active. Thanks.
Thank you very much, Larry, for that really interesting and lovely talk. So we have no little problem with our app, but that's why we're using the phone. So a couple of questions. At what age do you start CPAP with your CF patients? And are there any lung parameters, lung function parameters that you look at in regard to when not to do it or when to do it?
Okay, so generally we're starting around 8 to 10. Some of it depends on the size. You have to be able to fit on the bike, but also there's a certain coordination and breathing aspect. We use a mask rather than a mouthpiece. Mouthpiece tends to be drying, but you need a certain coordination and ability to concentrate to be able to do the exercise test. In terms of, is there a lower limit for lung function?
Yes.
Not really. The test colloquially is known as a modified Godfrey test because it was originally the exercise test was developed by Stuart Godfrey, and you take the predicted based on height, and you want it to finish somewhere between 8 and 12 minutes, but then you adjust for lung function. So if they have markedly advanced lung disease, then you'll do smaller steps. If you do the steps that would be based on if they were healthy in that height and sex, they're too big steps, they're going to stop early. So better to do smaller steps. I'm involved now actually in an adult study in patients undergoing rehabilitation before cancer surgery, and I'm just amazed at how deconditioned people are, and basically, if we thought they should have a 20-watt step, we're saying, no, do a 10-watt step. So you really need to look at the patient, not just height and their sex, but also take a notion of their lung function. Similarly, if I have, a young athlete who's coming in, I'm going to give them bigger steps because they're not going to be challenged with the steps that would be predicted from their height.
Okay, thanks. Just regarding the Activate-CF study, I have a question, and we have another question from the audience. In the control group, you saw an increase in FEV1, and this was prior to the start of modulators. Do you think that it was due to the placebo, or do you have any other explanation for increase in FEV1?
So, this caused a lot of sleepless nights for for the main PI, and we debated back and forth and squeezed the data as much as we could. We really do. It's more why didn't the intervention group, have it go up? And I think it was a small sample size. It could be, like I said, they were seen prior. Often they were on the verge of an exacerbation, and maybe that impacted it. But there didn't seem to be any obvious factor. But we were concerned that if you had starting people to do a lot of exercise that they hadn't done before, maybe it was just too much, and maybe it was having some sort of adverse, but that's really a hypothesis.
Right, okay, my second question related to that was, were there any injuries to commencing this vigorous activity?
No, actually, there was minimal, there was an occasional ankle strain or something like that, but it really wasn't. And I think the key was, the program was designed for each patient. It's not an exercise prescription. The patient was discussed what type of activities you like to do, what's your lifestyle, what's your life schedule, what happens, what's getting in the way of how you're doing things. There were some patients who ended up, going to a gym, and some gyms were very generous and said, we'll be happy to help them exercise and train and for free of charge. Other people said, this is the type of activities I want to do. So the idea was to really involve the patient, that it was their program that they were developing. It wasn't a program that was being imposed by somebody who had ideas.
Right. Okay, any other questions?
Thank you so much. Really appreciate you.
Okay.
And then
Our next speaker is Mark McClellan. He is formerly from Spectrum Health. It's now called Cornwell Health. He's also the clinical assistant professor of medicine at Michigan State University College of Human Medicine. Welcome.
You can only use this. You can only use that, yeah.
Okay. Do the up and down worker then. Good morning. Thank you for those excellent talks. I know I feel motivated to exercise now. I'll be talking to you about two topics today. Number one, the so-called CF baby boom, or increased pregnancies that are happening in the era of highly effective modulators. And second, we'll shift gears and talk about the decrease in lung transplants that we're seeing and the ramifications of that. And all of that with a respiratory and physical therapy sort of spin to it for this audience. And it's wonderful to be here today, isn't it, together? I have no conflicts of interest to disclose. I'm speaking to you today from the entity formerly known as Spectrum Health. Literally just a few weeks ago, we changed our name to Corewell Health in recognition of a merger. We are located in Grand Rapids, Michigan, or West Michigan, where we enjoy beautiful water and all 4 seasons, because we have no choice. We have seen tremendous growth in our program in the 15 years or so that I've been fortunate enough to participate. This is a curve that probably many of you have seen in your own centers as well. I attribute it largely due to better diagnostics and better care and longevity for our adults with CF. There are some local factors in our clinic as well that are playing into this, but this is a curve that really should make us happy, and we should continue to strive for this. We'll look at 4 things specifically today. We'll try to understand how highly effective modulator therapy is affecting pregnancy in CF. We'll recognize some special respiratory and physical therapy concerns in that patient population. We'll shift gears and talk about lung transplant in CF and understand how things are changing and what the ramifications of that are, especially for respiratory and physical therapists. And then we'll take a step back and talk more generally about the evolving mindset in the CF community as we transition from conceiving of a state of illness to more of what I would call a state of wellness. We'll begin by talking about pregnancy. I have Kendra's permission to use her photograph. In fact, Kendra wanted me to use her photograph and put her story out there. Kendra delivered her first child about 6 years ago, sweet little Holden there, when she had actually quite advanced lung disease, and with quite a bit of effort and counseling and work, we were able to get her through that pregnancy and deliver a healthy baby boy. Kendra went on to receive a double lung transplant, and a few years later gave birth to her sweet girl, Hayden. Both of those are very high-risk situations, and I'm not necessarily advocating that patients with advanced lung disease or transplants become pregnant, except with significant counseling and work beforehand. But I think we're all inspired by our patients. That's why we do what we do, after all. And their stories, I think, help to inspire and motivate us. So the CF baby boom is very real. Since the release of elexacaftor, tezacaftor, ivacaftor, the number of pregnancies in women with CF has increased 2 to 3-fold. Our own data at our own clinic supports this as well. In fact, my slides are already outdated. We've had 1 pregnancy even since I put this slide together. Some words about CF and pregnancy to help put things into context. Women with cystic fibrosis face a number of challenges when it comes to pregnancy. They may face pubertal delay, decreased fertility, risk to fetus, potentially risk to mother. The rate of infertility and subfertility is probably as high as 35% as compared to more like 5 to 15% for the general population. Despite these obstacles, nearly 80% of young women with CF express a desire to have future children. And women with CF are less likely to be using contraception. Probably somewhere between 25 and 50% of CF pregnancies are unplanned, believe it or not. So these are very real issues that we need to think about as CF care centers and talk to our patients about. Low lung function, FEV1 less than 50 or 60%, depending on what you look at, increases the risk of adverse outcomes. In addition, a lower BMI less than 22 also correlates with increased risk. Contrary to what was previously thought, there's probably minimal or no significant difference in lung function decline during pregnancy. In other words, pregnancy probably does not have much effect on accelerating lung function decline, particularly in the era of Alex-Tez-Iva. Highly effective modulators cause a number of favorable changes in cervical mucus and in pH. In addition, modulators improve lung function, as we know, and improve nutritional status. For all these reasons, we need to think very seriously about these ramifications and improve fertility as we counsel our patients. Animal reproductive studies appear to show no fetal harm demonstrated at normal human doses of CFTR modulators. And in addition, what data we have in pregnant women, while limited at this point to case reports and case series, do not appear to demonstrate harm with these agents. In addition, the miscarriage rate for women on modulator therapy has been reported to be around 4.7%, which is on par, or if anything, a bit lower than that reported for the general population of pregnant women. In addition, we know that stopping modulator therapy is often associated with clinical decline, both in case reports and in all of our clinics. Anecdotally, we see that. For all of these reasons, CFTR modulators are generally utilized and generally considered safe with appropriate counseling and informed decision-making. Again, data is not as robust as we would like, and the ultimate decision, of course, is up to the patient and their care team with appropriate counseling and thought. But in general, patients are continuing these agents during pregnancy. A word about respiratory therapy in pregnancy. Nebulized therapies are recommended to be continued throughout pregnancy. That includes really all standard therapies, DNase, hypertonic saline, bronchodilators, nebulized antibiotics. There are no trials that, as we know, compare specific airway clearance interventions one to the other, and a paucity of data in that, especially in terms of pregnancy. Our own center's approach is kind of keep using the vest until it doesn't fit any longer. In polling a lot of other centers, as I prepared this talk, that seems to be what a lot of you are doing as well. And then after that, there are a number of modalities, PEP therapy, oscillating therapy, percussive therapy, and so forth that are helpful. Upright position often helpful to minimize risk of reflux. And for sure, mechanical airway clearance should be continued and really, if anything, potentially intensified during pregnancy. While we don't have a lot of data yet, we're working to get smarter. The Mayflower study is a prospective multi-center observational study that is looking to enroll 285 pregnant women with CF. The primary aim of the study is to describe lung function changes during pregnancy among women with CF and to determine whether these changes differ based on modulator use or other factors. We're also prospectively collecting data on the infants as well to see how modulators and other factors are affecting their development. I just learned at the investigator meeting last night that happily we enrolled our 100th patient, so we are well on our way, and there should be more data forthcoming in future NACFC meetings on this, so stay tuned. From a physical therapy standpoint, pelvic incontinence is extremely common in the CF population. Probably anywhere between 30 and 68% of, depending on how you measure, women with CF have either urinary or fecal or both. This can have a negative impact on overall health and quality of life, but fortunately it's not without potential intervention. Pelvic floor muscle training or pelvic floor rehab given prenatally can prevent urinary incontinence for up to 6 months with a 30% reduced risk. And when given postnatally in women who already have established urinary incontinence, it can eliminate that urinary incontinence with a 40% reduced risk. The risk reduction is clearly related to the intensity of the program. I will tell you this is something that we in our program have been much more actively screening for, especially since we introduced our own physical therapist, Caitlin, to our team a little less than a year ago. This has literally been life-changing for a lot of patients. It's the kind of thing that often they won't bring up, but when you bring it up with them, they will happily talk about it. This is a big deal, so this is something I would really urge all of us to be talking to more about our patients. Finally, a slide that really makes me happy is this one. We talk a lot about moms with CF, and for good reason, but let's not forget about the dads. The curve in blue is our new CF mothers. This is at our own center, our new CF mothers, and the curve in red is our new CF fathers. And I think it's fascinating that these curves go up essentially in parallel, and no, they're not couples. No, I don't think that Alex Tezaiva is causing vas deferens to grow back, although that would be really cool if we find that happening. But I think this is saying that really it's more than about things like cervical mucus, right? But it's about changes in attitude, changes in perspective, changes in what people are seeing as their horizons. When we talk to our young men who are looking to father children, they talk about things like they feel like they're able to support a family better, they talk about financial considerations, and they talk about more of a long-term horizon. So I think this is really fascinating. I don't know that there's any information out there on this, but something that I think is worthy of further study. I'd like to shift gears and talk about lung transplant. For those of you who don't know Dylan Mortimer, Dylan is an artist with cystic fibrosis who has used his experience with CF and with lung transplant to inspire him to create absolutely beautiful and amazing works of art. In fact, Dylan has a kiosk outside the convention center So you're welcome to go up and meet him and see some of his artwork. So we're all familiar with this phenomenon, right? The patient who's humming along and gets put on Alex-Tez-Iva, and if I asked you to show me where this patient started Alex-Tez-Iva, you could probably point out the exact spot. It's right there. Seeing a nice increase in lung function, which is sustained. But what's cool is that this is happening not just for patients with mild or moderate disease, but for patients with severe disease. This is a patient with an FEV1 that had dropped well below 1 liter on oxygen, severely compromised, and got put on elexacaftor, tezacaftor, ivacaftor at exactly the point where you think, and then seen a nice increase in lung function. And this is a patient who literally came off of a transplant list, something that was absolutely unheard of in my 16-plus year career as a pulmonologist, is to see patients who can start taking a pill and not need a new set of organs. Absolutely amazing. The data we have thus far bears this out. This is an excellent data set out of France that came out last year, looking at all patients in the country of France with an FEV1 of less than 40% predicted, who were put on ETI therapy. At a very short time of 3 months, they saw an absolute FEV1 improvement of 15%, saw a rather robust and dramatic weight gain of 4.2 kilograms, and this is manifesting as decreased need for long-term oxygen, decreased need for non-invasive ventilation, decreased need for tube feeds. Our own data locally, again, bears this out. Patients with a pulmonary exacerbation dropped from anywhere between 30 and 40% per year down to, or about 4%. I think we had like 8 hospital admissions last year for CF. Absolutely remarkable. My partners, my fellow pulmonologists who don't do CF but help with some of the inpatient care are forgetting how to take care of CF because they don't see these patients anymore, I'm happy to say. The data set out of France looking at lung transplants, whereas previously more than 20% of those patients with severe lung disease were either listed or being considered for lung transplant, being actively evaluated. After introduction of Alex-Tez-Iva, that number dropped to just a few percent. Nearly all of the patients that were listed for lung transplant came off the lung transplant list. Pretty remarkable. When we think about the effect this has on patients, clearly many patients are overjoyed. One of our patients said, "I remember it like it was yesterday. They came in and told me my lung function was too good for a transplant. I was crying. It was the first time I had tears in a long time. I called my mom and my husband. It was great to feel good again. Of course, I wanted to get off that list." But I think we need to be sensitive that sometimes there may be mixed emotions with this. Another patient said, "I was happy. I didn't need a lung transplant. It's great to have better lung function, more energy, to not wear oxygen. Transplant lungs don't last forever. I want to keep my own lungs as long as possible." But she did go on to say, but it would have been nice to not need to do nebulizers and airway clearance, and I still occasionally cough up blood. That's a bummer. It would be nice to have normal lung function. I would like to be able to run one day. I can't do that right now. So I think we need to be sensitive that these are really transformative medications, and while it's mostly happy news, these are changing things in terms of patients' sort of trajectories and perceptions, body image. There's a lot that goes with it that I think we as providers should be sensitive to and listen to our patients. What is the future going to hold? Nobody knows. Whereas this was previously a sort of typical trajectory in a patient with cystic fibrosis, we'd like to think we're going to see this, but perhaps we'll see something like this over time where they see a nice increase in lung function, but maybe some decline over years. The effect of the medications, the modulators, seems to hold up in the short time they've been available, but we're still at a relatively short timeline. One thing is certain, and that's that patients will likely be living with their CF lungs for a longer period of time. And so we need to think about how we can make them healthy and keep them healthy. And as we just heard about in Dr. Land's outstanding talk, exercise is a key way to do that. Exercise intolerance is extremely common in cystic fibrosis. It's probably multifactorial. As a pulmonologist, I like to blame lung dysfunction, but there's probably more to it. CF patients have been reported to have decreased cardiac output, decreased peripheral muscle, problems with peripheral muscle impairment, diaphragm dysfunction, malnutrition, inactivity. CF patients on average are less active than their non-CF counterparts. In addition, low exercise tolerance in CF, as we've seen, is linked to a number of things, including higher mortality, loss of bone mineral density, and lower quality of life. Improvements in these measures are linked to a better quality of life. For all these reasons, exercise is an essential component in CF care. This is a slide you literally just saw in the last talk, but basically more active patients tend to be more physically fit. We know this. In addition, being more physically fit translates to a better quality of life, whether we're talking about physical functioning, whether we're talking about respiratory symptoms, whether we're talking about overall quality of life. There are clearly correlations. I would move that we should have a low threshold, an increasingly low threshold, to consider patients for pulmonary rehab. Pulmonary rehab is multidisciplinary and at its best includes at least 5 components: airway clearance, exercise training, both aerobic and strength, again, as we heard in outstanding fashion in the last talk, education, ideally a mental health component, and then a maintenance phase to importantly allow this to be sustainable, which is probably the biggest challenge of all. Last, but a very fun little piece of data that came out of Australia last year, a study looking at telehealth for physiotherapy. So this was in children who were in the midst of a pulmonary exacerbation, being treated with antibiotics, randomizing them to a conventional group of face-to-face physiotherapy, or there was a hybrid group that had a combination of face-to-face and telehealth, basically using the power of computers to reach people in their homes. And the combined group, the group that included some telehealth, had equal, if not slightly improved, return to baseline as compared to the conventional face-to-face group. Importantly, too, it was super efficient. Nearly 7 weeks of drive time was saved during the course of that small study. Thanks to COVID, we've all become much more comfortable and familiar with the telehealth platform, so we should increasingly think about this as an excellent application for respiratory and physical therapy. Even though we are seeing much, much fewer lung transplants, let's not lose connection with our transplant colleagues. We still have patients who have received lung transplants, and we will surely have patients who will, at some point in the future, continue to need lung transplants. One quality project that we're working on at my own institution is looking at joint telehealth visits between both CF and transplant. This is a patient who's seeing me in the CF clinic, and my transplant colleague is there on the screen joining us. Patients really are excited about this idea. It saves them a lot of time, travel time, visit time, decreases their burden of visits. Patients spend more time than we can imagine invested in their healthcare, so anything we can do to maximize their efficiency is really appreciated. So in summary, we're seeing a transition, right, from more old world CF, where we think about admissions, illness, and disability, into what I would call a bright future, proactive care, where we start thinking about things like family planning, career coaching, retirement, primary care, aging parents, mental health, things that take on a longer term horizon for many of these patients. One of my patients said, this was several years ago, she said that, you know what the worst part about being a kid with CF was? She said, nobody asked, what do you want to be when you grow up? We need to increasingly ask our patients, what do they want to be? And how can we help them to achieve that? Looking forward, we have many challenges. Pregnancy, what is the impact of modulators on the relationship between lung function and outcomes? I would argue that an FEV1 of 60% on modulators is very different than an FEV1 of 60% without modulators. There are clearly qualitative differences that we're seeing in terms of quality of life and how people are functioning. In transplant, how should selection guidelines take into the account the effect of modulators in terms of trajectory, illness trajectory? Transitioning from more reactive medicine to what I would call proactive care and taking on more of a long-term mindset. Thank you very much for your attention.
Thank you so much, Mark. We have a question here. It says, are patients post-transplant still expected to take Trikafta?
Great question. We could spend a lot of time talking about that. So in general, no. However, there are still patients after a transplant still have cystic fibrosis, even though they have nice, new, shiny, healthy lungs. They still have CF pancreas and CF gut and CF sinuses and CF everything else. So they're on a case-by-case basis that's considered. There are patients who, in our clinic, for example, post-transplant, who we have put on Trikafta usually for a specific reason. So one of the more common is like refractory sinus infections or sinusitis. We've seen it really help a few people in that context. Or for gut issues, people with recurrent issues like DOS, we've seen some benefit there. There's no good data to guide us, unfortunately, so it's a case-by-case sort of thing. We need to think about, there's risks, benefits, so there are clearly benefits even outside the lung to Trikafta, but there are risks as well, liver. Also, interaction with some of the transplant medications can be problematic from a pharmacology standpoint. So I think it's a case-by-case consideration. I've talked to other directors at other centers who kind of take a similar approach. We don't really know what the right answer is. Yeah, it's one of those things that hopefully as time goes on, we'll get more information in.
Okay, thanks. Another question was, are your therapists able to bill for telehealth? Many centres, the payers have stopped payment for telehealth visits, except for physicians.
That's a great question. I don't know the answer. I don't know if anybody else knows the answer to that. We at our center have not yet utilized much telehealth specifically for respiratory therapy or physiotherapy, so I don't know. You probably want to, meet beforehand with maybe the insurance and see if you could convince them.
Okay, there was just a recent article that came out that Brenda was telling me about with women who are on Trikafta during pregnancy, and there's been a report of 3 patients, 3 babies born normally without CF, but having cataracts. Have you heard this, or would you be concerned for a mother keeping on Trikafta during pregnancy with this?
Yes, cataracts are a potential risk with Trikafta. Both in animal studies with infants and potentially in humans. The recommendation is that infants be screened for cataracts. So infants born to women who've taken Trikafta be screened for cataracts. Yeah, that is a potential concern.
Okay, thanks. And could you comment on mothers still taking Trikafta and breastfeeding babies? How much is transferred to the baby during breastfeeding?
Yeah, so it does get transferred in breast milk. Sort of when you look at the recommendations and the guidelines, they say, it's worded something like probably safe. So again, we don't know with certainty because it's fairly new, but we haven't seen long-term ramifications in terms of breast milk. But again, the recommendation there too is women who are taking Trikafta and breastfeeding, that those infants be screened for cataracts.
One last question here. Do you ever see cases where pregnancy causes decreased lung function after birth as a result of pregnancy and then having to stay there?
Like anecdotally, have I seen that? I have. Most patients seem to do just fine. They make it through pregnancy, and we don't see much decline or any decline. But I have seen anecdotally a few cases where I feel like they had kind of more of a rapid decline during pregnancy. Whether it's related, anecdotes are anecdotes. It's hard to prove. You can't prove cause and effect. Maybe they just happened to get unlucky and had a bad exacerbation while they were pregnant. The data would suggest that on a sort of a wide scale basis, that's not a phenomenon that happens, but there's always individual risks, that can occur.
Okay, thank you very much for the talk very much. I just also wanted, before we close, I just also want to thank all of our speakers for their presentations, and I say keep tuned for next year because there's lots of trials coming out, but we haven't got the results yet, so keep tuned for next year and hopefully we'll have more information. Thank you.